Good afternoon, sir. Dr. Debashish here from JIPMER. Am I audible, sir?
Yeah, I can hear you loud and clear. I hope I am visible and audible from my end.
Yes, sir. So we'll just introduce you to our delegates.
Yeah, please, please. Whenever you are ready, I'm all right. I'm very, very glad. I'm not wish I am there in person, but I'm sure we had an interesting forenoon session with few live demonstrations. So it makes my life easy to share whatever my thoughts on this. People who want to take the journey as an ERCP specialist, especially the surgeons all waiting there.
Thank you, sir. We would now request everyone to join for this online lecture session, which is on tips and tricks of biliary cannulation by Dr. Easwaramoorthy, sir, consultant surgeon and surgical gastroenterologist at the Lotus Hospital, Erode. Dr. Easwaramoorthy, sir, did his MBBS and MS from Coimbatore Medical College. He then did his higher surgical training in UK. Sir is a passionate teacher and has trained more than 1,000 surgeons with the art of endoscopy by various courses across the country. Sir has also completed FRCS as Edinburgh, at FRCS as Glasgow and FRCS England. Sir has also been a member, is also a member of IMA, IAGS, AMASI, ELSA, and SGI. Welcome, sir.
Thank you. Thank you. Just I'll take a minute if you could allow me to share the screen. In the meantime, I just want to address the audience. It's a very great privilege to be here in the sixth JIPMER surgical update today. And I want to know out of the audience there, how many of them are already doing uh, thousands, if not hundreds of upper GI endoscopy and colonoscopy. Please raise your hand. I'm sure I just want to know how many of them are competent in the art of endoscopy, colonoscopy. How many of them are already doing ERCP? Please raise your hand. So hardly anybody. So I'm sure this is a field where we as a surgeon want to venture into, and there is always some attempts in various medical colleges, whether it is a purview of the surgeons. That is always the debate is going on. But I still feel if we are adequately trained, I think surgeons are perfectly placed to take this skill set, because now with the collaborative surgery coming in a big way, so one has to be, like I always say, laparoscopy and endoscopy are like your two eyes. So both if you are having, then you have a broader indications and you have a better understanding of the whole disease spectrum. So this is yet another field. It is no longer a frontier. The final frontier, yes, if people say, no, the final frontier, we keep shifting the frontier now. There are third space endoscopy. There is a sky is the limit for all of you enthusiastic. I can see lot of young, energetic postgraduates. I presume they're all postgraduates or senior residents sitting on the back. So they all be, I hope, they all take this endoscopy. And my job as a trainer is now cease to exist. Now you as a trainee today become a trainer in the coming years. Let me share the screen just to share my thoughts. I hope my audio is okay. Device, can you just tell me my audio is audible? I am audible. You are able to see my.
Yes, audio is clear, sir, and we are able to see the screen.
Are you able to see the screen now?
Yes, sir.
Thank you. Thank you.
Thank you, sir.
So thank you for this golden opportunity, JIPMER. I think this is, I've been there last surgical, I don't know whether it's probably the second one. And now the sixth one I'm online. And we are here having seen some of the ERCPs, how to get trained and what are the few things as a person getting started in ERCP ought to know. This is the thing. So my outline of the talk for the next 20 minutes is going to be what are the minimum requirements to start the skill set, how to do a selective biliary cannulation, what I mean by a difficult ERCP, what you do there, plan B and plan C, and what are the complications one has to be worried about or concerned about. Of course, a touch about ERCP training. Friends, you all know we are here as a surgeon to learn any technique for that matter, but ERCP is the one where you need a good team. A four-letter word ERCP needs, apart from you as a surgeon or an endoscopist, it needs a radiographer or radiologist, the anesthetist, and a staff nurse. Four people, bare minimum, to do this skill. And also, you need appropriate tools. But more than the tool and the team, it's a temperament that is very important. That's why all of you might have read about Peter Cotton, who actually coined the term ERCP. Yes, tools and teams are important, but more important is your temperament. You have to sweat a lot. There is a steep learning curve, all of us know. 20 to 30% of our time we end up doing. For example, you need to see at least 140 to 200 cases to get the skill set, and you need to get all the tools, and you have to explain to the team what is required. So preparation time is more than the execution time, or what I call the dry run. That is before the rehearsal is much more than the real run, because that is the you have only 1 or 2 times you need to cannulate. You can't keep on poking at the ampulla and making it angry and inviting a problem of pancreatitis. So you need to be very, very clear in your thought process. So for that, of course, the fundamental of any procedure, of course, is a clear understanding of the, I would say, the three-dimensional understanding of the ampulla and the biliary tree, pancreatic tree, where the major papilla opens in the medial wall of the second part of duodenum. 1.5 centimeter above and to the right is a minor papilla. And also there is a common channel, as we all know, in which the biliary and pancreatic duct opens, and the direction is also equally important. The ampullary opening is covered by what we call a sphincter ampullae, sphincter polydocus around the bile duct, pancreatic sphincter around the pancreatic duct is there, and the pancreatic duct is more horizontal in its course, whereas at 10 o'clock, if you think if you, in this position somewhere here at 10 o'clock, more vertical course is taken by the common bile duct. We'll give it in a different perspective, like here what I have written. If you think it is an ampulla, the commonest situation is the short common channel, all of us know. After about a centimeter or so, certain vertical course, a tortuous course is taken by the common bile duct. So you have to be very clear in your thought process how it is going to ascend up towards the 10 o'clock. Whereas more towards the 2 o'clock, more horizontal, going across this vertebral spine to the left upper quadrant is the pancreatic duct. Sometimes there will be a long common channel that will make things difficult for you. Very, very rarely there won't be any channel. There will be two distinct opening. This is very, very rare situation, pancreatic and bile duct separately opening. But this being common, let us concentrate on this particular situation. I'm sure you had 2 or 3 cases this morning, and the demonstration would entail starting always the side viewing duodenoscopy. The very important thing is, in addition to the objective lens on the side, it has a key thing is an elevator, which is controlled by next to the big wheel is another chap, that is the elevator, which you push it down, it elevates this elevator. So it is able to drive this, whatever tool you have, to the right direction. That is a very important thing. For example, as you elevate more, you can go a little higher up. So finger down, thumb down, the elevator goes up. So it's a very important control. You need to know how the elevator is working, and unless it is in a good pakka order, your success won't be possible. Next, of course, is clear understanding how the image intensifier. If you have a C-arm, well and good, or if you have a good image intensifier, you should know how it works when the patient is lying supine or prone, what position you want to keep, whether you have a X-ray compatible table, and you need to have a radiographer who knows what's in your mind. He should be having the mind reading of you. And of course, you need also, these three are becoming essential additions. I would say probably the irrigation pump may not be required in the beginning, but especially when you have a bleeding, yes, required. But CO2 insufflator is now becoming an increasingly a common adjunct, I would say, because explosion is hazard, especially when you do a spyglass and other things. CO2 is very important. Next, of course, I need not tell you the importance of the diathermy, the tissue responsive diathermy, the ERCP, because it can deliver the precise endocut eye, endocut mode, which is giving you an incremental cut with every pass like this. It is able to give you a cut and a pass, cut and pass like that. Even if you continuously press the yellow button, it is able to give you the prescribed, like here, pancreatic sphincterotomy done at 2 o'clock. So you are able to do that by what we call endocut I mode. Whereas endocut Q is another mode which is used for a polypectomy for that matter. So once you have all the hardware understood, now case selection as a beginner. I'm speaking from the beginner's perspective. And you need to know before you what to do, what are the cases not for us we should realize. In other words, relative contraindication, I would say. As a beginner, I don't think we'll be taking the MPM of gallbladder or Merit-Cyst syndrome for lap coli. Similarly, I won't do an ERCP in the first 100 cases if it is a too controversial indication, because ERCP is essentially a therapeutic modality. So we want to restrict it only for like a straight away CBD stone or obstructive jaundice because of the distal cholangiocarcinoma, things like that, not for a sphincter aortic dysfunction, which itself will give rise to some slight abnormal LFTs, but there it is a too controversial. The complications are also very high post ERCP pancreatitis. Too difficult, minor papillotomy in a patient with a recurrent pancreatitis, or ERCP in altered anatomy where the patient already had a Billroth 2. So these are the not case for you in the beginning, because that will put you back by a few years. I know you don't feel like doing it. Even for that matter, pancreatic endotherapy, not every case will be easy. It will be challenging for you. You need to have the right gear or a toolbox. And intrahepatic stones will be very, very challenging to navigate to the right and left system and see. So you need to have the right tool and the team in order to successful in all these scenarios. So avoid these scenarios. But for this, ideal case is a patient waiting for lap coli is having a stone in the bile duct. Yes, go for it. You do about 40-50 cases. Consolidate your experience, then slowly you go into more malignant cases. Coming to the procedure itself, per se, once the coagulopathy is looked at, vitamin K is given, prophylactic antibiotic administered, the anesthetist will ask you whether you want a conscious sedation or a GA. It is up to you. Vast majority of them are doing a conscious sedation, but I started doing under general anesthesia for my own, and I have a better cannulation rate in my opinion, and slowly shifting from the conventional prone position, which vast majority of them usually do the ERCP, we start nowadays doing in the left lateral, then turning into supine position. Because when we do a simultaneous single stage lap coli with the ERCP, then this helps you. Either you do the ERCP, as soon as you finish, then you deglove and then you go for lap coli, or the other way around. So that's also helps. So I start learning, and you can do the ERCP, the supine position also. Like here, for example, this patient just few minutes ago has undergone an EC gallbladder. After that, the patient is having a single stone in the CBD. We don't go for a CBD exploration, especially if the stone is small, the duct is less than 10 millimeter, then it's better and kinder to go in a natural way, that is by ERCP. This is the way. And just to give you an idea about our theater, so this patient initially in the left lateral, then supine. You stay here, your main key assistant is to the right of you, and then you have a radiographer, you have a head nurse, and you will have anesthetist also if necessary, and you have a recording team. All these things, and the C-arm will come whenever it is required. So all in place, you are ready to go. Then you go step by step, like what you notice probably in the morning. I think much more information. I'm just trying to put words into what you witnessed this morning. The challenge for the beginner is going to be the navigation, I'll tell you, because doing an end-viewing scope is different. Here you're doing a side-viewing scope. Half of the travel is going to be leap of faith, because with a side-viewing scope, we are not going to see the lumen clearly. You are only going to see a bit of a ball. So slide along the esophagus, get to the stomach, how you go to travel. My advice for all of you is this one. For example, how to intubate the esophagus. Normally, you have the big wheel and small wheel. Tip number one, the big wheel, you turn it slightly away from you. When you take the big wheel slightly away, then what is essentially a side viewing scope will become partly an end viewing scope, because it will be able to look down. So you'll be able to see a bit of a lumen. If you have the scope, as soon as you enter the cricopharynx, beyond the cricopharynx, big wheel away, you proceed. Then you'll have a better luminal view right up to the cardia. Then in the cardia, what you do blindly one important thing, that is clockwise you direct, that is around 80 degree to 90 degree clockwise you turn like a key. So it takes to the time right turn, you find the greater curvature, you walk along the greater curvature. What I call is a long route travel. So I go along the long route, then you will be able to see in no minute a sunset appearance of the pylorus. This view you will get it. So the key is you travel through the esophagus by big wheel away, then you turn the scope clockwise, so go along the long route, then you see this, and as the sun setting, that means you're entering the D1. Going from D1 to D2 is the most difficult thing for a beginner, and also shortening the scope is the next challenge. Those things you can do. For example, initially you will be walking along the greater curvature like this, entering and trying to see the ampulla. But this is not the efficient location. You need to have only 60 centimeters of the scope inside. In other words, the scope should be hugging along the lesser curvature like this. In order to move from what is a long loop into short loop, you need to do all these steps I've written here. You watch this video. What we have done, I'll just slowly turn to the right, small wheel away, push the scope. Then I start turning my body comes also. Then big wheel towards you, then you'll be going beyond D2, D3, then you'll be looking at the ampulla. In other words, once you finish all these key 6 steps and pull back, and incisor teeth will be at the mark of 60, and your side weighing will be saying end facing. It will be looking straight face to face the ampulla. That is what you need to have. So this will come after a few days of practice repeatedly. Thankfully, we have a simulator to do this exercise, because this is something which you can't do even an animal model, and you can't give it to a patient. So I'll tell you what simulator is the best to understand this particular thing. That is small wheel away, then push the scope. As you push, start turning your body, then big wheel towards you, and then you push it little further, then start pulling back. The last thing is a pull back till you have. But there'll be challenges every time. For example, commonest challenge for all of us in the beginning is you will be in the stomach, because side viewing scope is a bad. You won't see your direction. If you are having any challenge, my advice all of you is turn the patient to left lateral, because that's the way you used to do the upper GI endoscopy. That will help you in some people. And if you're not able to enter the pylorus, again, sometimes it may be really due to pyloric spasm or a stricture. Sometimes even after the sunset position, then you may have to do a CRE dilatation of the pylorus with the balloon deflated. You can go with the balloon as a guide inside the duodenum. Then of course, duodenum is the next challenge you'll get. Ideal is this one. This is a semi-long. This is a very long position. Sometimes minor papillotomy. Sometimes if you have this position, if you're able to get the stability, sometimes you do the minor papillotomy even in this long or semi-long position. But ideal for any selective biliary cannulation is this short position. And as all our palmistry are not same way, 2 papillas are never same. A classic papilla could be a small papilla, or down-facing pendulous papilla, or slit-like papilla. There will be various types of papilla. Usually, this one is a bit challenging. This is inviting, but unless you go well below, look, it will be difficult to cannulate. Sometimes you may have to do what we call a pre-cut accessotomy. This is probably fairly straightforward. It's attempting to do. But the most important thing for all of us is to get the ampulla at the right parking place. We start treating our monitor henceforth like a clock. If you just put it like a clock, you divide this into 4 halves. The top left quadrant here is your parking place for the ampulla, because I usually have 3 parking places. If you have a pendex endoscopy, here I park any pathology like polyp and everything, because 7 o'clock is the trajectory, the accessibility for upper GI endoscopy, the Olympus scope, for example. Whereas colonoscopy, all of us know it is access point is trajectory is around 5 o'clock. So you have it in the lower right quadrant. Whereas for ERCP, you try to get either in the center or more towards 10 o'clock. The perfect. So when you do that, then when you go with the cannula, it will go in the right trajectory. So this is getting this like engineering. So then it will become half the job is done when you park the ampulla in the right place. Next simple concept, big wheel is your friend. If you bring the big wheel towards you, okay, that's the language I speak, then ampulla comes towards you. If you take the big wheel away from you, the ampulla goes away from you. So towards big wheel comes, this is big wheel away, then it goes away like this. So this movement you need to well verse. Big wheel is a friend, it will take you either towards the ampulla or away from the ampulla. So like that you can small wheel, your body movement, and you're pushing and pulling. There are 4 or 5 degrees of movements you can have. For example, big wheel towards you, away. Towards you, it will bring you away. It will take you away. Same way, small wheel, you can turn right and left. It will take accordingly. So the finer adjustments, somehow you need to do once you lock the wheel, wherever you want, because the trajectory you need to get before you go into the amp, you need to get, or your body also to some extent, or hand movement. For example, little hand movement, you see how the ampullary opening can change. And also little pushing and pulling. Sometimes you've gone too deep, then you may have to pull back. Now pushing deep in, or sometimes pull back a little bit back like that. So all this in addition, elevator, and the 6th movement. So 4 movements here, and the 5th is the elevator, and 6th of course is the sphincterotomy itself can be adjusted. So there are so many things which can have control. So the key endotherapeutic accessories. For example, tomorrow you're going to order accessories. There are humpty number which one to order. The go-to the accessories, in my opinion, what I call the horses for a courses. If you're going for a sphincterotomy, go for the best one, in my opinion, is the microvasive Boston Scientific short nose one, or you have Olympus clever cut. Both are okay. And guide wire, you need to go for the hydroflective guide wire or a turmo wire. Zebra wires are not commonly used. And of course, you need to have the biliary balloon. You need to have a Dormier basket, various lenses and sizes of the stent, 7 French, 10 French, single pigtail, double pigtail, all these things to have various lens, 7 centimeter, 10 and 12, 15 centimeter. Everything is ready, but still the go-to one for me is always the, nobody uses cannula nowadays because instrument exchange is not required. As I already said, this bowing itself gives you another movement. So you can bow, ask them to bow accordingly. You can have a little elevation because when you have a biliary cannulation, little bowing will also help you. And also the pathfinders, angled or straight tip guide wires, either jag wire or Olympus Visiglide, or even a better when you have a very tight strictures, Cherumo wires, hydrophilic wires, they'll usually find their way and show you, especially when you have a challenges. Now, let me just tell you my thoughts on how to get our accessories into the bile duct, the duct of choice. It has to be not by your luck, of course. Sometimes by luck you get in, that is different. But you need to just precisely enter, planned entry, that is called, you have to try with your trick, not with your luck. The best analogy is, of course, is when the Arjuna was asked to aim the bird, he was aiming at the eye of the bird. Even I would say iris of the bird. So accurate, you need to have the 3-dimensional anatomy. You need to see the direction in which it is going to go. The hump it has to go, the camel's hump it has to go. All these things, if you have, slowly you will gain this. See, for example, how I already told you sphincterotomy first. We have to just kiss the ampulla with the sphincterotomy. Then some of you may be even having about a 2 millimeter of the guide wire poking outside the sphincter. So it will go. Not the sphincterotomy itself, the guide wire itself will be going. For example, if you see here, my assistant keeping a little bit of the guide wire outside, it goes enter, then guide wire followed by the sphincterotomy. Then you can go a little bowing, as you can see. The direction is towards 10 o'clock. Then guide wire, I say, he'll take us towards 10 o'clock, sorry. So this is the way. Do you inject contrast? If you ask me, normally I don't inject the contrast if this technique of guide wire first is successful. Because contrast, if it goes into the wrong duct, especially pancreatic duct, especially if it is more than 2 ml, then there is a theoretical danger of pancreatitis. But some people say in a patient with a difficult, challenging cases, a combined procedure, a little squirt like 1 ml, 2 ml of contrast, followed by essentially a guide wire directed. You go, if the guide wire goes up parallel to the vertebra, 100% you are in the bile duct. Across the vertebra, of course, you are into the pancreatic duct. You come out, again try. If you go on 2 times across into the pancreatic duct, even with the guide or itself, that is enough damage. Third time, lucky, you have to think, because already you have initiated the process of pancreatitis, how you have to minimize the complication. So maximum 2 or 3 times you can cannulate the pancreatic. So this is the way it has to go. I always say, DAD. DAD is a one mnemonic, the direction of the wire, that is parallel to the vertebra. Then my staff nurse start aspirating with a 10 ml syringe of bile. That's a good sign to see. And also, only if it goes in the bile duct, it goes very freely right up to the hilum or even beyond. Because otherwise, the wire in the genu at the pancreas, it gets stuck here most of the time. It never goes up to here. So the depth of cannulation is also quite deep. You achieved a deep cannulation. The direction by the C-arm is parallel, not across. Then you jolly well, you can start injecting, but never inject from below upwards. You start filling the system from above downwards. That is another important dictum you have to see. A dilute, 1:1 dilution we always prefer. So the steps are very simple. Be sure about the papilla. Sometimes they'll be hidden behind a hood of the fold of mucosa. You need to lift the every hood and look for the papilla. That itself may take some time for a beginner. Scope in a shortest position. Trajectory you need to plan like Arjuna. 10 o'clock is a look for. Then you need to go freely, like without harming. The insinuation should not be forceful. No drop of blood should be there at the end of the cannulation. The direction is quite steep, as you can see. So you have to look. The scope should be further lower than the ampullary opening. You go this way, not horizontally. This is what very important thing is to know, that if you look at the end facing the ampulla like this, the touching point of the ampulla is somewhere here. Like for example, your trajectory is more from right to left like this. Whereas if you want to cannulate selectively pancreatic duct in a case of endotherapy, then you need to kiss the ampulla at 2 o'clock position. And you need to turn your position like this, like as if you are looking at the ampulla, that is from 7 o'clock here, you look towards 2 o'clock. So this is from left to right, pancreatic duct. This is from right to left, more vertically. So this is the thing you need to repeatedly rehearse in your mind, trying to understand. The another way is to be delicate, like what we call the roundworms, how naturally they cannulate several times without harming the ampulla. Like that, you need to be very, very delicate. One of the things people will advocate is like a CD method, because sometimes, even though you know the direction is this way, that is towards from left to right, sometimes the ampulla will be facing this way. So first you have to touch the ampulla, then try to just adjust its position as if there are 1, 2, 3 CD discs are in alignment. Then you align them, then you slowly go. In other words, it's a step-by procedure. One step, then slow. So in every step, have a further micro steps like this. You go right, left, then straight like this. Especially as I said, pendulous or a lot of grooves if it is present, this will have a floppy ampulla is very challenging. So there you need to see how you put all the 3D CD disc in alignment. You go this way, this way, then you go in like this. Here how it is. So this is the way you do. One of the challenging plays is short the common channel with a hump here. So there we use 3 important technique. In other words, don't be too away from. So you come close to the ampulla, big wheel towards you. Then pull the scope, shorten the scope upwards. Then you bring the elevator down. Then you just get in. So this is the way. In other words, already you insinuated, but it is not entering, means it is not able to enter beyond this. So that way you have to go a little closer. So you go close, pull back. So this course, which you straighten that hump, then you'll have a sense of giving way. The guide wire will go easily. So like that, there are various techniques available. So as late as yesterday, we did one case. Just quickly give you collectively what I have just said. Intubation is a key, and like the long route, sun setting appearance. Go to the second part, park the ampulla. Don't go away from it. So you bring it to the top left quadrant. Then you cannulate, selective cannulation, do a sphincterotomy. Once the cholangiogram showed what it is, then adequate sphincterotomy, then balloon sweep. Make sure that balloon is not inflated. You have to be according to the size of the diameter of the CBD. Several times balloon sweep, so take the sludge and stone out. Then occlusion cholangiogram we do, keeping the distended balloon at the lower end. Then you can put a stent at the end, especially when the patient is waiting for a lap poly. Even if you clear the duct, it's always sensible what urologists they do. Leave a stent, be happy, because you never regret having had a problem of cholangitis or a residual stone later. So check cholangiogram, stenting. I always go for a single pigtail stent. So the migration, Amsterdam stent or a straight stent has a small risk of migration upwards. Avoid that also. The challenging cases are this one, like if you have a periampullary diverticulum, don't get worried. Sometimes it's much easier than we think, especially there is a large periampullary diverticulum with most of the time it will be on the right side of the diverticulum ampullary opening. But only thing is sphincterotomy, you can't be very liberal. You should be careful. If they are diverticulum on either side, there may be an ampulla in the middle. Sometimes even it may be inside, then only there will be challenge. There are lots of tricks of the trade, especially for them. But you tried long enough and what to do. Peter Carton and also all these people, they have said, okay, Nip Sukendra, they said, you can't keep on having one technique, then you'll, so you need to have another accessotomy, like a pre-cut, plan B, plan C. Because 5 minutes gone, 5 times you attempted, you every time you're going to pancreatic duct. So that means it's a difficult, maybe patient related, maybe anatomically there may be a problem, or maybe a technical challenge. So what do you do? So you should always have a plan B. My plan B is go for an accessotomy or a pre-cut, especially as a surgeon. It's a procedure which you should not take as a last resort. Preemptively, I go earlier than late. Second, of course, is a pancreatic cannulation you already done, means leave the guide wire there and take it as an advantage. The other two is for not for the beginners, rendezvous procedure, EUS guided, especially if you have a team where you have your colleague doing EUS, yes, of course, that can be tried. Or plan C is even better. That is, you come another day or ask your senior to do. So never hesitate. Don't have the ego, because here is a patient who, if you do it badly, is having a danger of getting into very bad pancreatitis. So keeping that in mind, always keep the plan C. Abandon the procedure, ask for help. So as I said, accessotomy pre-cut, especially a stone impacted right at the ampulla, biliary pancreatitis. Very simple, easy case. No role for biliary cannulation with the sphincterotomy. Go straight for this needle, the diathermy. You just lance it like an episiotomy, starting from the ampulla towards 10 o'clock. The bile will be pouring, then you can cannulate. So this is the easiest one of the thing. And the pre-cut, here another demonstration of the pre-cut. So all you need is a needle, and endo cut eye can be used, or you can use a the pure cut also you can do. As I said, it is cut, cut, cut. Don't stand on the pedal, going for a zipper cut. It's always incremental cut with pause, and go layer by layer like a cutting an onion. Sometimes you'll be able to only cut the duodenal mucosa, then you'll be able to see the biliary mucosa clearly, then you can go and cut. Even though there is a theoretically slightly increased chance of perforation, if you take care as a surgeon, very seldom you get into trouble. Next, of course, is the easier case is when you have a tumor right at the ampulla, especially periambulary tumor with a bulging ampulla just above it. The easiest thing is due to a cystostomy. That is, you don't worry about the tumor trying to cannulate through the friable tumor. Just to go a centimeter above, and you can make a hole in it, then you can get in. So it can be either endo ultrasound guided, or you can go with a bulge. Very often you can succeed in this. So pre-cut may be of various types. And few pieces of advice I like to give you all is quickly is, if you have a lot of stones like this stag, don't try to pull them all together. You just take the last one by one. You take one at a time, because otherwise the whole thing can get impacted at the ampulla. You'll be getting into trouble. So don't pull them all together. Go from the lowest one by one. That is a rule number one. The second thing is inline pulling. This is the second important tip I want to give. For example, when you have a stone here or a sludge here, and you are sweeping the bile duct with a balloon, when the balloon comes very close to the ampulla here, don't pull like this. It should be in alignment of the bile duct. For that, there are important three things I want everybody to learn. I'm sure it might have been demonstrated today. One, of course, is a big wheel away from you, so that when you take the big wheel away, it goes away. So it goes away like this. So it pulls thing. Second is push the scope down further to D3, then rotate the scope clockwise. Okay, so when you do that, the thing slips out. The distended balloon will slip out nicely, taking all the stone. Even the big stone can be dragged or negotiated outside by this triple technique. Big wheel away, push the scope, clockwise twist the scope, push and twist the scope, then it'll just nudge it. Don't pull the balloon itself. The pulling the balloon this direction slightly upward, it will not do the trick. So you need to be in inline pulling, what I call. This is another trick you need to learn from the experts, how they are doing it. The final thing I wanted to share with you is a double wire technique. Sometimes, as I said earlier, you each time you keep going into the pancreatic duct. What you do is you leave the guide wire in the pancreatic duct. Then with your therapeutic scope, you can leave the guide wire, still the same sphincterotome can go through the same channel like this. Then you cannulate. So what will happen is now the guide wire is already closing the opening of the pancreatic duct. The likelihood of you now entering the bile duct is greatly increased, especially when this is straightened by this technically. So you'll be able to enter fairly easily, much easier than what you thought. Then you can confirm, of course, by an image intensifier, like going right parallel to the system, not across like what this is the PD and this is the pancreas, the bile duct. Once you've done that, illuminate by giving a contrast. You can see this is a post-ERCP patient. Then you do wide liberal sphincterotomy. Don't go right up to the horizontal last fold. Okay, leave a centimeter or so. And make sure you're going more towards the 10. Otherwise, there is a chance of excess bleeding there. Once you do that, at the end, either you can take the guide wire or preferably you put a pancreatic stent. That is recommended. And also, if you're worried about this guide wire coming out, you can either put a stent in the pancreatic duct initially. Upfront, you put a stent, pancreatic duct stent. After that, you can also cannulate. So here is a case of where you put a stent in. Small 5 French stent will do 7 centimeter. It will fall off by itself the next few days. After that, once you're happy, then you can go in just above. See, the pancreatic stent is being placed. Then you can cannulate. So this is another technique. It avoids doing a stent. But having said that, sometimes the stent, it'll make the cannulation a little challenging. I think as I've tried both the technique, I prefer the double wire technique where wire alone may not be such hindrance. Whereas if you have a stent, sometimes it may be hindering your cannulation. Sometimes you may have to do a accessotomy. So as I said, friends, the complications are there, especially the post-ERCP pancreatitis, real problem, bleeding, if you are not too careful, and also if the coagulopathy is there, you haven't given vitamin K, haven't brought the INR down, and disinfection of the scope is very important. Prophylactic antibiotics is a third generation cephalosporin is very important. Risk of perforation is there. If you're too careful, that is very rare, but it can happen to anybody in the beginning of the career. And one thing you have to be very careful, if you don't detect the perforation, infection, vision, even 1% mortality is there. So don't take ERCP lightly. So you need to be very careful, especially for post-ERCP pancreatitis. We are very often preemptively keep the patient on 100 milligram of indomethacin suppositories, plenty of, they hydrate the patient, and the pancreatic stent where and when indicated. And coming to the training proper, there is no shortcut to success. All of us know. I don't think I have any better options, but I want everybody to climb this Everest, Mount Everest, 180 to 200 cases. Then only your cannulation is close to a respectable number. That is around 80 plus. Because initially when you have easy cases, you become super confident. Then you start having failures. Then you will really need whether it is going to be your piece of, but persevere another 100 cases, by 200 cases, then you will be more realistic. Then slowly you ascend, non-stop there. So first you easy cases, then slowly take some challenging cases, but accept some failures there. But with your mentors, with your seniors, ascend in that path also. So this double hump, what I call, is your path. We have various modalities to teach youngsters in the art and science of the biliary cannulation. One thing we have tried is this Costa Magna mechanical thing, wherein you can navigate the D1 and D2, and they have a disposable ampulla wherein you can even practice everything, stent insertion and everything. So this is a very good one. Repeatedly you can practice. For a better tactile feedback and other things, you can have an easy animal model also. But here the ampulla is in the first part itself. It's not a realistic ampulla, and you can't teach them the how to shorten the scope and other things. For that, I think I put money more on this. The next, if you don't have easy animal, go straight to the simulator, especially symbionic simulator is another one. There they have about 20 case modules wherein you spend about 10 hours. There it will teach you various therapeutic modalities also. Even though you don't have the haptics as good as here, but still it is a good trick. So you need to see. Once you have done enough cases with the mentor, don't have any doubt in your mind. You are legally permitted to. Every surgeon is permitted to do what is right for the patient, especially. Because when the patient has a problem, we can do open surgery, laparoscopy, or endoscopy, or even sometimes radiological intervention. It is up to us. Okay, but safety of the patient is paramount. We need to have the credentialing as and when. Keep the logbook, record all the documentation. When you have any problem, please get the seniors. You have to have a mentor, because ERCP is not for everyone. It is only for the people who have the passion to perfect any art and perseverance. As I said, you need to climb two mountains, one shorter and one bigger one. And as Keita Cotton said, you have to sweat a lot, at least in the beginning. Persevere 95% of the time. But I'm sure there's a long way to go. But as a surgeons, I can see 10 years ago, there were less surgeons were doing endoscopy. Now I am very, very heartening to see when I travel across the country to see more and more are enthusiastic coming forward to learn the skill. Initially endoscopy, now colonoscopy, even third space. It is very, very heartening. So you need to have the skill so that surgeon teaching surgeon. So the tomorrow we may not have a scope unless we have the skill of flexible endoscopic techniques. Thank you.
Thank you very much, sir. That was a wonderful lecture from you. So now we will have some questions from the audience, I think. So before that, I would like to ask a question. Today, we had 3 cases in the ERCP workshop. In the last 2 cases, Dr. Mahadevan demonstrated the double cannulation technique, double wire cannulation technique. And in the last case, he showed this pancreatic duct stenting. Over that, he did the pre-cut and cannulated. So my question is pancreatic duct cannulation is easier than biliary cannulation? Because the last 2 cases, whenever he tried, it was going freely into the pancreatic, entire thing. So that is my first question. Second one is, after doing this pre-cut papillotomy, how do you recognize that bile duct? He could do it nicely, but I was wondering how it was looking very small, but he could cannulate. So these are 2 my questions.
Your first question is right, especially when you really want to enter the pancreatic duct, that time it will always go in the bile duct. So this is the catch-52 situations always. But normally by nature, because unless your scope is further below the ampulla, you go upwards. Very often in the beginning, you tend to go more horizontally, you end facing, you end up going through the pancreatic duct. That is what happening very many people, especially in the beginning. But the main thing is we have to recognize. And the last thing you want is to inject. Now I don't inject at all. 100% you should avoid contrast injection. That is the rule number 1. And the main thing is how you position yourself matters a lot. As I said, for a pancreatic cannulation, you need to face as if you are facing at 2 o'clock. You need to face the monitor and you have to face 2 o'clock of the monitor. You have to look, you have to have your trajectory where you are standing, how you are going to have the cannula, and you are end facing. You are not going upwards. In other words, the elevator, you are not pushing it completely down. It is halfway down. So it is going this way, not that way. So like that, it is a multi, you learn the trick after some time, but if it goes 2 times, no hard feelings. As I said, it has a tendency to go, leave the guide wire there, and it will be an advantage. Don't think, and it will be definitely help you. Then you can go like a double wire technique. It is something which you've already seen 2 times. I think that is a nice way to start. So there is always a challenge. I mean, solution circumvent all the challenges we have. The second thing coming to the pre-cut, yes, normally people think pre-cut is actually much easier than the cannulation, to be honest with you. The problem is we always go too deep in the beginning itself. You need to slice layer by layer. You need to have the cut. Initially, you always cut the duodenal mucosa and keep this knife. And with a knife, you just sip the edge of the duodenal mucosa sideways, trying to, and just to give some irrigation. To see the classical horizontal small, the capillaries on the surface of the bile duct. So you'll be able to appreciate the bile duct. Little bulge of the bile duct will be seen very often. Because where you have this pre-gut is only when there is a obstruction right at the ampulla. Because of the obstruction right at the ampulla, there will be a little bit of bile just above. So the bile duct will be a little distended, you will be able to. So incrementally, you just cut. A tinge of bile is a sign, a green signal, as you have just opened the. So you keep clearing area, suction, you can attempt one, then bile will start dribbling through a small hole. Then you just take the guide wire, directed the sphincterotomy, go through that hole, then you will cannulate. So it is just a trial and error. I am sure it is only a layer by layer cut. Don't have a lot of bleeding. The bleeding will make the spoil the whole play. That is the thing. Bleeding when you have, you will be vaguely going, and you fear in your mind is, have I cut all the layer? Am I going out with the duodenum? That is the fear everybody will have. And it is, take it from me, cutting through and causing a perforation due to the pre-cut is very rare. The perforation can happen some other way, like zipper cut, or when you when you go the intubation, initially people have perforated even the second part of the duodenum. This pre-cut very seldom causes a problem. We fear more, but actually that's why people always undercut. But that's where I come as a surgeon. We all confident surgeon, we know. So we usually, as a pre-cut is better done by surgeons. I feel I'm very strongly vouch. We can easily teach a layer by layer cut, avoid bleeding, and that is the secret, I would say. Any other doubts or comments? I really appreciate Vishnu Prasad, Professor, and all the colleagues there. And you can see Uday and all other are sitting there. Nice to see you all. And it is always, I can see the galaxy of speakers are coming tomorrow and day after. I didn't understand the intensity because I had a problem, a course here in our behavior in the medical college this morning. Otherwise, I love to travel there to be with you because wherever the endoscopy, I am the first person usually there across the country. So I love to be there next year, if not this year. And thank you once again for this excellent opportunity to interact with you.
Any more questions? Sir, one last question I would like to ask. Which company's side wing scope is better? Is it Pentax, Olympus, or Fujinon, or the training makes the person better?
I think training is very, very important. As I said, all the three are now equally good. Actually, they are competing with each other because what will happen is, unlike the upper endoscopy where the trajectories differs, here almost all the three scopes are more or less same. Because because even though I have Olympus, I can vouch for Olympus. Most of the conference when they go, they give appendix or Fujinon. Fujinon scopes are excellent nowadays, I would say, and Pentax colonoscopy is good. So all the scopes, it is not the mix, it's the man behind the machine matters, not the scope itself, in my opinion, as far as the ERCP is concerned. The optics are quite good nowadays. High definition is there. So there is no doubt in my mind, all the three are equally good.
Hello, sir.
Hi.
Sir, regarding this structured ERCP training program, what will you suggest for the, particularly for the surgeons?
Yeah. See, this is what we are contemplating. Initially, we started course, something like a 4G course, that is advanced course, single theme ERCP. But now we feel that is inadequate because the number of days we allot is not enough. So we want to have it like a fellowship. So ideally, you should have a therapeutic, the theoretical background for a few days and need not be on site, it can be online. Then you need to have an intense 2 or 3 days of 20 or 30 cases you have to see done by so many people. They sweat a lot. You see the difficulty they face. Then you have to attach to an institute at least for a minimum of a month where they have at least 5 or 6 cases a day. You see them preoperatively, assist them, post ERCP, be with them, and see how it works. So if you do all these things, and you should have seen by the end of this 1 month at least 100 cases, then you go back wherever you are. If it's an institution, you go there. If already somebody is doing, you ask him to give a part of the procedure to you, support him, assist him there. So you assent. In other words, you see the first 20, 30 cases only by expert, then one institution for another 100 cases, then in your own institution you go another 50 with somebody assisting you, 150. Then that is the way you progress. The whole thing, the median time it takes is around 6 months in my opinion. This we are actually planning in IAGS. We are going to a center of excellences. So we are identifying the willing, because it is initial teaching is the easy part which I can do, but we need to find about 5 to 10 institutions where we can send each one as a traveling fellow. You be there at least, if not a month, at least for 1 or 2 weeks. So you see enough number of cases, go confidently, because the skill set it should be comfortable. Then you can go ahead. So this is the way we are structuring. This is still evolving, but we'll get there eventually by end of this year or two. Because our IAG is pushing it. I am sure there are other similar surgical associations are pursuing it. Don't worry about MCI. MCI never you take into this algorithm, because there is nothing like ERCP you should not do or should do. It is, we are having our own doubt in our mind. That's all I would say. If you are competent to do a procedure where a surgical condition warrants the procedure to be done laparoscopically, endoscopically, open surgery, you do it, provided you ask 2 questions: whether you are competent to do it, whether you do it to your own father or a sister or brother. If your answer is yes, yes, go ahead. This is the way we see, we push it. Eventually, we will get the accreditation MCI, but it is a long road. I think we all to be there. It's a collective efforts. We are going in the right direction. Now, all of us are confident doing endoscopy, colonoscopy. 5 years down the line, I'm sure same thing echoed for the ERCP alone. Also, at least for the biliary endotherapy and single stage ERCP, lap chole, it's a must for all the surgeons, I would say. Actually, HBB surgeons.
Okay, thank you, sir.
So that was a wonderful interaction with you, sir. It was as if you were here. So
Thank
we
you, sir.
enjoyed your talk. So on behalf of the Department of Surgery, I would like to extend my sincere thanks to you. Thank you very much.
Thank you. I'll sign off from my place, Lotus Hospital. My greetings to you for a successful next 2 days, and look forward to meet you, have further academic collaboration in the coming years. Bye-bye.
Thank you.
Bye. Thank you.
So that is the end of our workshop. So my sincere thanks to all of you for coming to this workshop. You can have the tea now. Thank you very much.